Hi, my name is Catherine Poulos, and I'm a psychiatric nurse practitioner located on Long Island, New York. Several years ago, I began to notice around September, approximately 1 in 10 of my patients would begin to report depressive symptoms, such as hypersomnia, increased appetite, especially for carbohydrates, weight gain, fatigue, or low energy, and social withdrawal, a phenomenon we often refer to as hibernation. But interestingly enough, these symptoms would tend to resolve in the spring without any major intervention, though uncomfortable for the patient. These patterns are characteristic of seasonal affective disorder. It's SAD, which according to the DSM-5 is not a separate diagnosis, but rather an add-on specifier for major depressive disorder, MDD. So that seasonal pattern basically is a specifier that indicates that the episodes of the depression occur at a particular time of the year, usually fall or winter, and remit another time of the year, typically spring or the summer. So, as a clinician, I wanted to explore the interventions that were effective yet natural, avoiding any drastic pharmaceutical or invasive options. This curiosity led me to investigate the potential of vitamin D supplementation as a means to improve symptoms of seasonal affective disorder. So, here we go. Let's explore it together. Now, let's look briefly at why sunlight has such a powerful impact on our mood. As seen in the diagram, there are several biochemical steps through which UVB exposure is converted into compounds that enhance brain function and emotion stability. When the sunlight reaches the skin, it triggers the conversion of 7-dehydrocholesterol into vitamin D3. The sun is therefore essential in the endogenous production of vitamin D, which plays a direct and indirect role in the brain health and neurotransmitter regulation. One of the key mechanisms involved is the tryptophan TPH2, which is an enzyme found in the brain that serves as the rate limiting step in the synthesis and the breakdown of serotonin. And as we know, serotonin is a crucial neurotransmitter associated with mood, motivation, and well being. So, when sunlight exposure decreases, such as during those winter months or prolonged indoor activity or higher altitudes, the resulting drop in vitamin D levels may downregulate that TPH2 activity, leading to reduced serotonin production. This biochemical cascade is one of the leading explanations for mood changes seen in seasonal affective disorder. Something also to consider is vitamin D supplementation exists in primarily two forms: vitamin D2, derived from the plant sources and fortified foods, and vitamin D3, which is synthesized in the skin under UVB sunlight exposure or obtained from animal based products such as fatty fish or egg yolks and liver. Most multivitamin supplements use vitamin D2 because it's less expensive. Selecting the appropriate form of vitamin D is crucial for our patients because some have dietary restrictions, such as vegetarians or vegans. Research has shown, though, that vitamin D3 tends to be more effective than vitamin D2 at raising and maintaining adequate serum vitamin D levels, which may have greater implications. So, when looking at mood regulation and seasonal affective disorder symptoms, it looks like we may have to look at vitamin D a little bit more closely. Now, knowing what we do know about the importance of sunlight in mood, as a clinician, I wanted to explore an evidence-based answer to an important question. What does the current existing literature and research say about vitamin D supplementation for SAD, seasonal affective disorder? To investigate this, I conducted 4 literature searches using a combination of keywords, and these searches yielded approximately 60 articles, from which 5 were identified as being particularly noteworthy due to their strong methodology and clinical relevance. From this review, several key takeaways emerged. The first, randomized placebo-controlled trials showed mixed but promising outcomes. Okay. Number 2, Meta-analysis supported the benefits of vitamin D supplementation in deficient populations. This implies that correction of a deficiency can lead to the relief of symptoms. Number 3, vitamin D deficiency is a modifiable risk factor, meaning that vitamin D insufficiency has been linked not only to depressive symptoms, but also to a variety of chronic and medical conditions, such as bone disorders, weakened immunity, and cardiometabolic diseases. So, through sunlight exposure, diet, or supplementation, clinicians can help patients address a correctable biological vulnerability. Number 4, a lack of standardized screening and supplementation protocols in clinical practice. So, despite the growing awareness of vitamin D's role in both physical and mental health, there are no universal screening or dosing standards for SAD. This variability leaves many patients underdiagnosed and undertreated. So, as clinicians, we have the opportunity to change that by integrating routine vitamin D assessments into our seasonal depressive care plans. And let's continue. So, let's talk about the target population. Looking at adults with recurrent mild depressive disorder with seasonal affective disorder, SAD. Again, it starts in the fall and remits in the spring or the summer. They also have subtherapeutic serum 25-hydroxy vitamin D levels, and the patients would reside in New York State. And just to look briefly at the inclusion criteria, though I went through a lot of them that I can think of, age 18 to 65 years, living in New York, and they would remain through the duration of the study. They meet the criteria for the DSM-5 for depressive disorder with that seasonal affective pattern. They also have a symptom threshold at baseline for the SAD, which is a outcome measure. The vitamin D level would also be drawn in the beginning of this study, and they would be able to be available to have it drawn at the end of the study, and that they also have treatment stability. Nothing new has been started in the past 6 weeks. And just a few other inclusion criteria might be that the patient does not have any additional treatments that are planned for SAD, such as the lightbox therapy or Dawn simulators, or the addition of bupropion, which is Wellbutrin, which is indicated for SAD at the time of enrollment, that they have the capacity and the consent availability. Also that the follow-up is feasible because this is going to be a long study, and the patient will consent to this. So with inclusion criteria also comes exclusion criteria. And the prominent one would be anybody with bipolar spectrum disorder or psychotic disorders, suicide risk. They have any active psychotherapy that they just started that have not been stable within several weeks. In thinking about the medical component of it, this is more exclusion criteria. Basically that people who cannot metabolize vitamin D correctly. More exclusions would be people who had already had adequate vitamin D levels and they wouldn't need the supplementation for the purpose of the study. People who are pregnant or breastfeeding, that may have to be excluded. People who are on certain medications that might compete, that would be rendering their medications ineffective. People who are also planning to travel to a sunny location during the study period time would also be excluded. So in simple language, I'm looking for adults ages 18 to 65 who reside in New York, who experience mild to moderate winter depression, and that usually resolves in the spring to the summer, who have a low vitamin D level at the start of the fall, and who aren't taking any other changes to their current treatment. As we stated that they need to be available for all the follow-ups and the endpoint. They will be given an evaluation and monitored using the SAD scores and the vitamin D levels. I also feel that patient education is essential so patients understand what they're taking and why. And let's continue. For this project, I decided to keep things simple and focus on two main outcomes: changes in mood and changes in vitamin D levels. The first outcome measured would be using the SAD. It's a structural interview guide for the Hamilton Depression Rating Scale with a seasonal affective disorder component to it. It's one of the most widely used tools for assessing both the severity of depressive symptoms and seasonal patterns and mood changes. I plan to administer that at baseline in September and again over the course of the 3 months, monthly, to capture the changes over the course of the darker season and into the spring. Also, we're taking a look at is the vitamin D level, the serum D hydroxy vitamin D3. This is a standard blood test for assessing vitamin D levels, and I'd measured it again at baseline and again at 3 months to determine whether or not supplementation raised the patient's vitamin D levels into sufficient range, typically above 50, and whether or not there's a correlation between the changes of the SAD scores and the change of vitamin D with the patient's improvements and tracking their mood. So, in summary, this small project aims to explore something that many of us in clinical practice have long suspected, that vitamin D may play a meaningful role in the seasonal mood changes. And by tracking both the SAD scores and the vitamin D over the course of the fall and winter, I hope to see whether improving vitamin D status can translate to a better mood and energy for those struggling with seasonal affective disorder. So, even though the existing research shows mixed results, there's a consistent message across many studies. People who are vitamin D deficient often feel worse in winter, and correcting that deficiency is safe, simple, and potentially mood boosting. What's encouraging is that vitamin D is a modifiable factor, something that we can test, monitor, and treat without introducing major risks or side effects. From the clinical standpoint, this means that when a patient presents each fall with low energy, hypersomnia, carb cravings, and social withdrawal, in addition to screening for depression, we may also look at their vitamin D level. If it is low, supplementing with vitamin D3 could be a gentle, natural starting point before moving to more aggressive treatments. This project can best be understood through the health belief model, HBM, which explains and predicts how individuals make decisions about their health behaviors. The model is built around 6 main concepts: perceived susceptibility, perceived severity, perceived benefits, perceived barriers, and cues to action, and self-efficacy. In the context of seasonal affective disorder, SAD, and vitamin D deficiency, each of these components applies in a meaningful way. Perceived susceptibility. Many adults living in the northern climates like New York may not realize how vulnerable they are to developing low vitamin D levels during the fall and winter months. Helping patients understand their personal risks, such as limited sunlight exposure or fatigue that often worsens seasonally, builds awareness and motivation to act. Perceived severity. Seasonal depression is often minimized or seen as winter blues. By educating patients on how low vitamin D and reduced serotonin can impact mental health, clinicians can reframe SAD as a real biological influence condition that deserves attention and care. Perceived benefits is emphasizing the benefits of vitamin D supplementation: improved energy, mood, susceptibility, better overall wellness, helps patients view it as simple, natural, and worthwhile preventative measure. Perceived barriers may be that some patients may resist supplementation due to the cost, forgetfulness, or skepticism about its value. These barriers can be addressed through education, affordable supplementation options, and regular follow-up encouragement. Cues to action. Seasonal cues such as shorter days and colder weather can serve as a reminder to check vitamin D levels or begin supplementation in early fall. Clinicians can reinforce these cues through patient education, reminders, and annual fall wellness visits. Self-efficacy. Ultimately, patients who believe that they can manage their own health are more likely to follow through. Providing knowledge and simple steps like taking vitamin D3 daily, spending time outdoors, and monitoring levels empowers individuals to take control of their seasonal wellness. Viewed through the lens of the HBM model, this project is not only about improving lab numbers, it's also about changing beliefs and behaviors around preventative self-care. When patients understand the link between sunlight, vitamin D, and mood, and they feel confident that they can do something about it, they are more likely to engage in proactive behaviors that support emotional well-being. Ultimately, my hope is that this kind of awareness will encourage more clinicians to routinely assess vitamin D as part of their approach to managing seasonal mood changes. Within the health belief model framework, vitamin D supplementation becomes a motivating, self-directed action, a small but powerful step that can help patients feel more like themselves even through the darkest months of the year. So, in summation, let's look at this trip sheet implementing vitamin D supplementation to improve seasonal affective disorder. As we discussed, we reviewed the target population, the evidence highlights, the vitamin D and serotonin cascade along with the sunlight, the methodology, the theoretical framework of HBM, the outcome measures. We looked also at the conclusion and how it translates to practice. I hope you enjoyed this, and I hope you look at vitamin D supplementation during those fall months a little differently for your patients.